This is Advanced Patient Care Theory 2, Unit 6, Part 2, Spinal Trauma. Okay, so spinal cord injury, the pathophysiology, the cord is divided into 31 segments, and each with a pair of anterior, which is the motor, and dorsal, which is sensory nerve roots. The vertebrae, there are 7 cervical vertebrae, 12 thoracic, 5 lumbar, and 7 sacral. And as you probably heard, giraffes have 7 cervical vertebrae, same as humans, only they're much longer than ours. And you can review these dermatomes if you like, but I won't test you on these. In the ER physicians will assess dermatomes in much more detail, but they'll get assessed in even more detail up in the intensive care unit, and the purpose of that is to get an idea clinically of where the cord injury is. For you and me, I think minimal time on scene is important, because there's going to be, in addition to the cord injury, there's going to be a swelling that occurs, and that swelling needs to be mitigated. In hospital, they may give them corticosteroids of some sort to mitigate that swelling, and that may save a dermatome or two. There have been numerous studies done on administration of corticosteroids for spinal cord injury. Some results positive, some results somewhat indifferent about it. The types of vertebral injuries that we see involve sometimes compression, where people fall from a height, landing on their head or landing on their feet, or comminuted fractures, as we see down here, the vertebrae. And you can have partial cord injury or complete cord injury, or it may start out as partial cord injury, and then the swelling cuts off the blood supply to that area, and it becomes a complete cord injury. So, generally speaking, if you encounter a patient who's got a suspected cord injury and they've got complete loss of motor sensory function below a certain level, there's probably not going to be a full recovery of mobility or sensation. There might be some partial recovery. If you encounter someone who's got partial motor sensory loss, then there's a better chance of recovery. But you and I don't convey a prognosis. That's not a discussion that we have with the patients. Our communication is simply, here's what's happened and here's our concerns, and we're going to take you to get treated. So, sorry, these bullets are a little out of sequence. So, the cord, like the brain, is relatively well protected within the vertebral canal, and it's also surrounded by cerebral spinal fluid, and that gives it some shock absorption. And but subluxations, which is a displacement of the vertebrae by less than 25%, dislocation greater than 25%, can cause cord injury, cord damage. And even jarring of the cord within the vertebral canal can result in swelling, and like the brain, there's limited room to expand. So if the swelling is great enough, if the bleeding is great enough within an area, over time it can compress the cord, kind of like a compartment syndrome, and start to cause deficits. And so there may be spinal shock, and spinal shock is really a description of the cord injury that occurs as a result of swelling. It's not the same as neurogenic shock. Neurogenic shock is the result of a complete cord transection and loss of vasomotor tone. Right? We see that in high T spine and C spine injuries, not in lower injuries, and not in cases where there's swelling in the vertebral canal. So, with a complete cord transection, or even with spinal shock, it might lead eventually to complete loss of neurogenic function, including reflexes and rectal tone, below the specific level that's associated with that cord injury. So, if you look at this X-ray of the C-spine, this is C1 and C2. Can you see where the subluxation has occurred? Which level? No, it's not C1, C2. It's not 2, 3. It's not 3, 4.
It's 6.
It's right. That's right. It's 5, 6. Yeah. So C1. If you look along the line here, so C1, C2, they're all fine. C3, 4, 5, and 6. You can see 6 is displaced outwards, right? So 6 and 7 are out here like that. So that's the area of the subluxation is 5 on 6. Yeah. And like I said before, when you're in hospital and you drop a patient off and you come back later, talk to the physician. And most physicians would be thrilled to show you the x-ray and show you what happened and tell you all about it. And they're great educators. And it's nice to develop a rapport with the docs as well, because you know that you gain some respect from them when you show some curiosity. So cord injury syndromes, let's talk about. So you can have concussion of the cord, you can have incomplete transection, complete transection. Neurogenic shock, as I mentioned, refers to hemodynamic triad. So that's hypotension, bradycardia or relative bradycardia. So where you have a patient who's got a pressure less than 90 and they've got a heart rate of 70 or 80, that would be considered a relative bradycardia, because you expect them to have a reflex tachycardia, but if their heart rate's normal, that's a relative bradycardia. And peripheral vasodilation. So these are the patients who have loss of, simply put, neurogenic shock will be in patients who have loss of motor and sensory function below the nipple line, and they'll be hypotensive, bradycardia, relative bradycardia, and they'll be warm and dry, and they'll have spectacular veins for IV access. That's the neurogenic shock patient, classically. So there's a loss of autonomic function, and there's an interruption in sympathetic nervous system control from acute spinal cord injury, and disruption of pathways that normally give us a fight or flight response, so tachycardia and vasoconstriction. And so generally, hypotension shock occurs in injuries below T4, below T4 are invariably above T4 rather. So below T4 are invariably hemorrhagic shock in nature. So in terms of assessments, we do our ABCs with C-spine precautions, obviously, and our assessment needs to be focused on their respiratory rate and effort and their hemodynamics. So if they've got injury to 3, 4, and 5, there's a saying, 3, 4, and 5 keep the diaphragm alive. If they've got injury to that level, they may have depressed respirations, and it may be very subtle. So look at their SpO2, but look at their chest wall movement, and whether they're abdominal breathing or not, and look at their rate. But it's usually their tidal volume that's compromised. So look for decreased SpO2, CO2 if you have the luxury of monitoring CO2. Hemodynamically, hypotension, relative bradycardia, large accessible veins. Neurologically, we want to figure out at what point there's loss of motor and sensory function, and we can do that just by simple touch. Warm, dry, normal skin color. There may be priapism present. That may be present in paraplegia, not just quadriplegia. So the other thing to look for, which I neglected to put on the slides, is in C-spine injuries we often see spastic flexion of the arms, and so IV access at the antecubital level may not be such a good idea if you're dealing with quadriplegic, like a high loss of motor sensory function, because if they're not in spastic flexion now, they may experience some spastic flexion down the road in the next few minutes or so. So I usually start IVs in the hand or the wrist, and large bore IVs, 18s, 16s, 14s. So very high lesions, C1, C2, vital capacity, so breathing may only be 5 to 10%, and the cough reflex is usually absent. And these patients will require PPV. C3 to C6, vital capacity is only 20%. Normal cough is very weak and ineffective. Some dangerous mechanisms. Just let me go back to that spastic flexion of the arms. I was at a conference years ago, and I sat in on someone's talk on spinal cord injuries, and at the end of his presentation, he showed these teenagers who were riding mountain bikes, and they'd set up this wooden ramp, and one of the guys on his mountain bike went off this ramp and went over his handlebars and landed on his head and rolled. And he was lying on his back, and they were all laughing. This is a YouTube video. I haven't been able to find this YouTube video since. They must have pulled it down. And they were all laughing. And when he landed on his back, both his arms immediately went into spastic flexion. And I knew instantly that he'd severed his C-spine, or severed his the cord at the C-spine level. And so I was talking to the guy who gave the talk afterwards, and I said, that poor guy is paralyzed. And he said, how do you know that? I said, because, if you replay the video, you can see the spastic flexion in his arms, and that's classic of a quadriplegic, like an acute quadriplegia. So some dangerous mechanisms. These are from the Canadian C-spine rules. Falls from equal or greater than 3 feet, which is 5 stairs. I had a lady who hang on a second here. I had a lady once, an older lady who fell on the sidewalk. She was out for a walk, and she fell, and a couple of other ladies stopped to help her out. And we got there, and we just thought it was a fall with a bump on the head. She's lying on her side on the sidewalk, and one of the ladies is kneeling over talking to her. And we get out, we pull over, and we go there, and I sort of thank the ladies, and we talk to this lady, and she's unresponsive. We turn her over, check a pulse. She's VSA. So we ran the arrest. We got a pulse back eventually, took her to the hospital, and she had a C-spine injury just from walking on the sidewalk. So you got to watch for C-spine injuries in the elderly from lesser mechanisms. Point I was trying to make. So axial loads to the head, so diving, landing on the head. Motor vehicle collisions greater than 100 kilometers an hour, rollover, ejection. It's interesting, we sometimes complain that the speed limit is 100 kilometers an hour, but if they were to increase the speed limit to 120, so 120 kilometer hours increases the risk of injury and disability by 30%. So it's disproportional to the increase in the speed limit. So we think 120 is nothing, right? But it is significant, and that's the reason we have a speed limit of 100 kilometers an hour. Motorized recreational vehicles are a common cause of serious cord injury, bicycle collisions, simple rear end MVCs, what excludes pushed into oncoming traffic, hit by a large bus or truck, rollover, and high-speed strikes to the back of the vehicle as well. So delayed might be, not immediate onset of neck pain, and this is from the Canadian C-spine rules. So cord injury management, we're going to obviously, look to support the airway with simultaneous C-spine control. And breathing, we need to watch for subtle changes in breathing, and look at SpO2, but look at their tidal volume, their respiratory effort, and you may have to do PPV with these patients and coordinate with their own breathing, and just explain what you're doing and why you're doing it. And for neuro, you can immobilize. Just know that pressure sores can occur in as little as 20-30 minutes, and sometimes can last a lifetime. So how you immobilize them is your discretion, but just on the mattress of the stretcher is perfectly fine. And SpO2, cardiac monitor, O2 if they've got if their minute volume is compromised and they're not oxygenating well and their sats are lower. supplemental O2 and transport. And IV fluids for hypotension. Now you get a couple of choices for, let me see if it's on the next slide here. Oh, okay, it's right there, the next bullet point. So you get a couple of choices. If they're hypotensive, fluid resuscitation is fine. I think it's my personal preferred approach, 20 cc's per kilo. Dopamine is another option because they're vasodilated, right? My personal experience, and this is purely anecdotal, and I don't know that it's a good justification, but when you work here, you'll deal with a lot of cord injuries. You'll deal with a lot of head injuries, a lot of cord injuries, a lot of trauma. And I've had a lot of cord injuries, a lot of neurogenic shock patients. And my experience has been when I put them on dopamine, they vomit. And it's not good to have a vomiting patient who's paralyzed. So at one point we started sort of getting away from dopamine and just fluid resuscitating them. And you can give them 30, 40 cc's per kilo, just enough to get their blood pressure up to about 90 or so, so that they're awake and their brain is adequately perfused. Someone's got the mic on. Were you going to say something? I assume that's a no. Okay. All right, so pros and cons of intubating spinal cord injury. Any thoughts about pros and cons?
You have more definitive management, especially if they're laying on their back.
Yeah, more definitive. Okay, I can't remember if I've got bullets for this stuff. No, I don't. Okay, let's go back. Hang on a second here.
More definitive, but more challenging.
Yeah. So
as they are laying flat, they have a collar on, have a neck injury, so how you actually intubate would be more delicate and more limited. And you might be focused on only using a Miller blade versus a MAC.
Now, why Miller blade versus the MAC?
Just due to the way the airway is going to be positioned in this patient, that you might have more success by using the Miller, as if, let's say, they had neck immobility as their normal. I would presume the Miller is just going to be able to grab more, see more, and do more, because the airway is not going to be able to move as easily as it would have had to use the MAC.
Yeah, I can't argue for that or against it because I haven't seen any evidence to that idea. Is that coming from some evidence somewhere?
I remember I did a intubation style course with Sunnybrook, and they advised that would be something beneficial to use.
They did, eh? Interesting. Okay. Yeah. In my entire career, I've only ever used a Miller for kids. So that's interesting. So it'd be interesting to see if there's actually evidence to support that too. So, or if that's just opinion based. But certainly, the trauma docs at Sunnybrook have the credibility for it. Because I did my training, my critical care training under the ER docs at Sunnybrook, and I remember over the course of my first 10 years of teaching, there were things that I taught that I learned from trauma docs that I later found out weren't evidence based, and you would have thought, given the fact it came from those guys, it's got to be evidence based. But yeah, I mean, if that's her opinion, that's interesting. So I'll just add to a con. They may improve and need to be extubated. What are some other pros and cons?
Easy to manage if you have to extricate.
Okay, yeah.
A decreased risk of aspiration if they do vomit.
Yeah, good point.
You may inadvertently cause further injury in the process of laryngoscopy,
Yeah,
even with a C-collar.
fair enough.
Well, in your experience, did you actually visualize sweat lines in your spinal injury patients?
You know what? I've never looked for a sweat line, never seen a sweat line. Sweat line is, we were taught sweat line when I went to college in 1983, 84. I think it's I think just based on personal experience of limited value, and I've seen a lot of cord injuries. You know, if you see it, you see it. I think it's a good observation. I just don't know what the sensitivity and specificity is of a sweat line. So, good question. I'll just add, you know, one of the cons is may cause vomiting, just the process of intubating. And, that's a problem as well. So I think you can think of a number of causes. I would be reluctant to intubate a patient with a cord injury. Certainly, I wouldn't do it at all if I can manage them with PPV. Usually, the issue is, and someone's got an open mic, just FYI. Usually, the issue is that they've just got a decreased minute volume and they need some support. Now, it's a different thing if they've also got a head injury and a cord injury. They've got a head injury, a cord injury, and not a readily reversible altered mental status, then intubation might be in the best interest. Now, to intubate them, you're going to undo the collar or remove the collar completely and just have someone manually immobilize the head. But airway comes before C-spine. So if the act of doing laryngoscopy is going to cause some movement of the spine. It's inevitable. They've shown this with cadavers. It's just going to happen. So when you do laryngoscopy, if you can do a blind nasal intubation, that might work, and you can keep the C-spine completely immobilized. But if you're doing an oral tracheal intubation, just know there is going to be some C-spine displacement, and but airway is a higher priority. You know, I would say if you got a conscious cord injury patient, you're not likely to get an order to intubate. They're going to expect you to try to PPV them because they're going to be breathing spontaneously, and you're going to supplement their tidal volume. So you've got a copy of this slide in the Canadian C-spine rules, and we have our spinal motion restriction protocol now, so I would just review that. Any questions about spinal trauma?
Why didn't they incorporate that rule pretty much word for word in the DLS and chose to opt in for this SMR thing instead?
Yeah, I honestly don't know. But it's a dynamic document now. They call it a live document, and there are going to be changes over time. I contacted a buddy of mine at EHS branch, and they're interested in adding research references to the standards, which I'm really excited about. So I offered to help with that, and I think, you know, there are lots of really smart people in this industry, and if any of you are interested in volunteering to get involved with that when it happens, if they contact me, I'll let you know. But I think it'll be good once that they decide to go ahead with that. We'll get the word out to add some evidence to that. But yeah, I mean, Canadian C-spine rules. I've been following personally. I've been following Nexus and Canadian C-spine for the last 25 years. I haven't been following the BLS standards at all, and I don't know why they didn't reference the Canadian C-spine. It might be because I think a combination of Nexus and Canadian C-spine is really the ideal approach. Nexus I like because it's simpler. Canadian C-spine is good, but it's just a lot of there is a lot of memorizing of the different criteria. I'm just waiting for you. Sorry, go ahead.
When it comes to transferring these patients, the previous thought was, of course, the spinal board, you drag it over to the bed. Now we're able to put people on our bed, put them in even a sitting position. Yeah. What's the best way to move them from bed to bed, though? Are we to immobilize that spine through that transfer, or just a sheet drag?
I would just do a sheet drag, just a careful sheet drag.
Yeah.
But again, if you've got no motor or sensory deficits, you're probably not worried. I mean, the chances, years ago we used to harp on this, you could convert, a vertebral injury without deficits to one with deficits, but the chances of that are so remote. Unstable C fractures are rare, but C-spine fractures are common in trauma.
Oh, wow. Maybe I should.
And so I think just careful movement. Just as when we're extricating patients, I haven't used a KED in at least 20 years, and I just see no value in using a KED, especially if they're significant trauma. Then we want to get them out with just careful manual immobilization of the spine.
Okay, thanks.
Any last questions? Okay, let me wrap up the recording here.